Thanks, Alyssa. Good afternoon and perhaps morning for some. I'm Don Weaver, Senior Advisor for Clinical Workforce at NAC, and will be serving as your moderator today. I want to thank each of you for taking the time to join us. Our audience is varied. It includes individuals brand new to dental therapy, along with national experts that have been working on expanding access to dental care through the addition of dental therapists to care teams. Our hope is upon completion of this orientation to dental therapy, everyone will be able to accomplish what our three learning objectives were. You'll be able to describe the role of a dental therapist on health center dental care teams. You'll be able to develop an outline of the steps that need to be taken at the state and local levels to add dental therapists to your team. And finally, you'll be able to decide if you'd like to continue this journey in a peer learning community. As Alyssa mentioned, our orientation is divided into segments. We'll have Q&A after each segment. In addition, we have allotted time at the end for general Q&A. If you're like me, sometimes the question doesn't come till two speakers later, so you've got a time to do that as well. Please place your questions in the chat and we'll try to get to all of them. If not, we'll certainly get back to the group as a whole. Since there are bios included at the end of the slide deck, my introductions of these amazing individuals will be brief. Today, our NAC welcome will be provided by Rachel Gonzalez Hanson, who is currently serving as interim president and CEO of NAC. Rachel served as CEO of Community Health Development Incorporated, a health center in Uvalde, Texas, for 34 years prior to joining the NAC team as senior vice president for Western operations. Rachel will be followed by Mike Holmes, NAC's board chair, who has served for over 40 years as CEO of Scenic Rivers Health Services, a health center in northern Minnesota. Mike will be joining us in our second segment, talking about Scenic Rivers Health Services experiences with dental therapists on their team. Rachel?
Thank you, Don. And thank you all for joining us today. We really appreciate having you. We all realize the importance of good oral health for an individual's overall well-being. And the NIH publication from 12/2021, Oral Health in America, truly laid out the paths for optimal oral health for all. That is why we are excited about this program and the positive impact of adding dental therapists to health center teams. This will clearly support our efforts to expand access to healthcare and addressing health inequities. It is a critical time to have this conversation. And given the massive pressures on our workforce and immense need for improved oral healthcare services, especially for the underserved communities. As with all of our work, partnerships are definitely essential. We are pleased to be working with NOAA, Pew Charitable Trust, Community Catalyst, our academic ally, A.T. Still University, the College for Health Communities and the Underserved, and many others to accomplish our goals for this project. Again, thank you for being with us. And now I'd like to turn it over to Michael Holmes. Mike?
Thank you, Rachel. Welcome, everyone. Thank you for joining us today on this kickoff session on the orientation to dental therapy. Lack of access to dental care is a serious health issue, especially for the underserved populations we serve. They have significant access issues and access barriers, and it affects our low-income populations, our uninsured populations, populations of color, the elderly, people with disabilities, and rural populations. Back in 2010, one of our Minneapolis-St. Paul FQHCs documented more than 10,000 visits in 1 year to Twin Cities emergency rooms for dental-related problems, such as toothaches or abscesses. The cost of these visits was more than $4.7 million, and the treatment, providing an antibiotic, didn't address the underlying issue. There were a significant number of factors that contribute to the access problem in the metro area, but the most significant component was a shortage of dentists to provide care. 15 years ago, Minnesota passed legislation to create two new types of licensed oral health professionals, a dental therapist who works with a dentist on site, and an advanced dental therapist who works under a collaborative practice arrangement with an off-site dentist. Health centers across the country face the same issues that Minnesota FQHCs faced. Issues of access and shortage of dentists available to deliver care to our patients. And as we look at NAC's strategic pillars, in order to meet our commitment to equity and social justice and care for America's underserved, we must increase our workforce that reflects the communities we serve, and we must update and improve our care models to meet the evolving needs of our communities. Use of dental therapists in our practice teams help us achieve these goals of expanding dental access to care nationwide. My organization has used dental therapists on our care teams since 2018, and I'll talk more about our experiences with the program later and our use of therapists on our care team. And at this point, I'll turn it back to Don.
Thanks, Mike. And Rachel, I know you've had to fit us in to a very busy schedule and will not be able to stay for the entire session today. It is recorded, so you can view it at your leisure, but thank you so much. And just I can say personally, having had the opportunity to visit you in Uvalde when you were the CEO, I know how important oral health is to you in making sure that we care for the whole person. So thank you, Rachel and Mike. Our first segment will focus on answering the question, what is dental therapy? And as you can see from the speakers list that we have, we'll hear from two individuals. We'll first hear from Jeremy Crandall, NAC's Director of Federal and State Policy, who will provide an overview of dental therapy. Prior to joining NAC, Jeremy worked on state-based issues at Blue Cross Blue Shield, the Pew Charitable Trust, and in the state of Maryland. Jeremy will be followed by Katie LaVisca, who has practiced as a licensed dental therapist since 2012. Katie is a graduate of the first dental therapy class at the University of Minnesota and currently works at Southside Community Health Services, a health center in Minneapolis. Jeremy?
Great, thank you, Don. Really appreciate that introduction. Good afternoon, friends and colleagues. As Don mentioned, Jeremy Crandall with the NAC Public Policy Division here. You could very much consider what I'm about to say in the next 7 minutes or so as your very early starter appetizer in terms of introducing dental therapy. There are a number of speakers after me that really are doing the on-the-ground work or otherwise engaged on this topic that are going to cover in much more detail what I'm about to cover. Having worked in and around politics for around 15 years now, I am sometimes prone to embellishment. In this moment, this is not hyperbole. I cannot describe how excited I am to be a part of this panel and to talk about dental therapists. I did spend 4 years at the Pew Charitable Trust on the Pew Dental Campaign. It was both one of the coolest jobs I ever had, but also the most exciting part was I was able to work with an amazing group of passionate and fiercely committed people working to address what I believe is one of the most glaring inequities in access to care, and that's in the space of oral health. So if we go to the next slide, please. I'd like to begin my remarks by very briefly telling the story of Diamante Driver. While the story of dental therapy does absolutely not begin with Diamante, it is definitely one of the most impactful chapters. And I would say that applies beyond just dental therapy into the entire realm of oral health policy. For folks that are not familiar with Diamante's story, he lived approximately 10 miles from the US Capitol in suburban Maryland. At the time of what I'm about to tell you, he was simply in need of an $80 filling or otherwise procedure that ultimately would have saved his life. However, due to a number of circumstances, he wasn't able to get access to this routine dental care. His mother was uninsured. They had very significant difficulties finding Medicaid dentists that could treat him. His family had also lost their Medicaid coverage. And the other challenge was his mother was focused on finding a dentist for Diamante's brother, who was also having some severe oral health challenges. But ultimately, bacteria from an abscess that he had went to his brain, spent 6 weeks in the hospital, had 2 operations, but he ultimately succumbed to this. And so I was actually working in the Maryland legislature at the time. For anyone who is participating in this session who is familiar with Diamante's story, it is hard to overstate the impact that his death had. It set off a renewed wave of national efforts that were also already underway, but really saw added commitment of resources and time and effort from national groups like Pew and Community Catalyst and many others to rededicate significant time and energy to addressing the oral health gaps and challenges that exist in America. Next slide, please. We would very much argue that the facts bear this, and it's not an argument. I would say that the facts are what they are, that they bear this out. 60 to 70 million Americans live in a dental professional shortage area. Just 30%, and that number definitely varies by state, but approximately 30% of dentists in the United States see even a single Medicaid patient each year. And of course, these gaps in access to care disproportionately impact Black and Latinx people, low income, American Indian and Alaska Natives, people with disabilities, and people living in rural areas. And it absolutely shows up in our emergency departments, where people have to go to the ER to receive treatment for what are otherwise preventable dental conditions. The picture on the left here is something that absolutely still frustrates me. It's a picture of a Missions of Mercy session where oral health providers hold open sessions, if you will, for people to access free dental care. While this work and the work that the providers do in these sessions is so important, it is frustrating that this is a key element of America's approach to dental care for underserved people. Next slide, please. So with that table setting, let's start talking about dental therapy, which, as I said, you will hear so much more than I'm about to share over the next hour about how dental therapists help directly address these gaps in access to care. First, a quick primer. So dental therapists are licensed oral health professionals that are trained to provide both preventive and limited restorative care that Katie's going to talk more about. They're specifically trained to provide expanded access to care in areas with chronic shortages and for underserved populations. They customarily practice under the general supervision of a dentist, and again, other panelists can speak to what that means, and are proven highly effective at bringing dental care directly to where people are, whether that's in a health center or other type of in-facility care and treatment, or out in the community as well. Next slide, please. So this is absolutely a key theme. I will say in my previous professional life, this was a big reason why Pew was so supportive and interested in dental therapy, is because there's overwhelming evidence related to this profession that show how effective dental therapists are at improving access to care. And I'm not going to read every single one of these data points, but I want you to take a look at them, because what they absolutely paint a picture of is the dental therapists improve access for people on Medicaid and from other underserved communities. They improve the provider productivity and improve patient satisfaction. They improve oral health outcomes. And another key piece of this, because at the end of the day, having worked for NAC for more than 2 years now, health centers have to work hard every single day to keep their doors open from a revenue perspective. And dental therapists absolutely contribute in a meaningful way to helping health centers do that. So next slide, I have two more that I'm going to go through relatively quickly here, and then I want to turn it over to our other panelists. We'll go more in depth into this, this key piece of this as we work through this project. We call this a kickoff meeting on purpose, because that's what it is. This is just a first conversation about dental therapy. But it is really important to understand that dental therapy is ultimately a state-by-state effort. It ultimately lies in state legislatures and state governments to authorize this provider, just like any other. And so that was the effort that I was involved in my previous profession or previous role. As of today, 13 states have authorized dental therapists to practice in some shape or form. It is exciting in what I'm about to say that this map that you see is already out of date. I understand that Montana recently authorized dental therapists in some form as well. But what we very much, one of the goals of NAC's work, I've had Pew on the brain for the last 7 minutes. One of the key pieces of NAC's work over the next year, as many of you from individual states that may not be shaded in here are thinking about this, what does that environment look like? And if you already have authorized, then what does implementation look like? But next slide, please. And this is going to be my last one. This is absolutely a key theme and we were actually just talking about this a few minutes ago. To think of dental therapists, it's important to think in other types of providers, that have seen an expansion over the last 50 years. And I found this chart actually when I worked at Pew, that was a snapshot of the evolution of nurse practitioners over the last approximately 50 or 60 years. And what you saw is there was a slow adoption and then really an explosion where ultimately every state went about establishing them. And that is absolutely a goal, I would say, for folks that are advocating for dental therapy in this community. And I think we're seeing that evolution right now as well. So Katie, I'll stop there, turn it over to you.
Hi, my name is Katie LaVisca. Don already gave me a great introduction, so I won't talk too much more about myself. Again, I was one of the first graduates from the University of Minnesota. I currently work for a FQHC, Federally Qualified Healthcare Center in South Minneapolis. I have been privileged to speak on behalf of dental therapy at several state Senate House hearings and sessions. I'm very passionate about it and hope to continue to do so for the decades to come. I am the current past president of the Minnesota Dental Therapy Association. Great website if you guys want to check out and have any direct questions, good resource. Next few slides are just me and the family. The next one is the kiddos that occupy most of my time outside of the office. So jumping right into dental therapy here. So there is some confusion as I'm traveling to different states of the different programs. So I'm mainly going to speak to Minnesota. So the University of Minnesota and the Normandale Metro programs were the first one to start. This past fall, another school opened a dental therapy program in Mankato State in South Rural Minnesota. So there are different programs in Minnesota. They're all dental therapy educational programs that have been approved by the Minnesota Board of Dentistry. I think it's always important to note that students have to pass a comprehensive competency-based clinical examination credits. And it's interesting to note that the patient board is the exact same as the dental students, and there's a blind proctor. So they don't know if they're grading a dental therapist works or a dentist work. At the University of Minnesota, we go to class with the dental students and the dental hygiene students. We take the exact same examinations. There's absolutely no difference. Our scope of practice is just smaller. And then we're also have to pass the jurisprudence exam in Minnesota, just like the dental students and the dental hygiene and the dental assisting students. You have to submit an application for licensure. Both programs, all three, currently graduate dental therapists. In Minnesota, you have to practice the 2,000 hours, and then you have to take an examination, you interview with the board, and you have to submit patient portfolios to get your advanced certification. So even when you read that the school graduates ADTs, advanced dental therapists, it's true, but you have to practice for 2,000 hours and do all of that before you get your advanced certification. The University of Minnesota is now a dual degree program. So you get your dental therapy and dental hygiene, bachelor's of science, and a master's in dental therapy. The Metro Mankato State, you have to be a hygienist before applying to the dental therapy program. Most states are following this model, as I understand it, where you're a hygienist before you get accepted into the program. And they graduate with a master's of science in advanced dental therapy. So if there's some confusion about the different programs in Minnesota, that is why. It's because there's a few different programs. So again, this is kind of what I already went over. Oh, next slide, please. And then, yep, we'll talk a little bit about this later too. There are different levels of supervision. Correct in that dental therapists have to have a dentist on site. Advanced dental therapists can practice under general supervision. So the dentist does not have to be on site, but that doesn't mean that every ADT practices under general supervision. I'm an ADT in my current practice. There's always a dentist available, but I have worked under general supervision at several clinics in the past. So that is the main difference besides some scope of practice between the DT and the ADT. Next slide. This is just kind of from for the Minnesota Board of Dentistry website. If anybody just kind of wants like a real quick breakdown of the different scope of practices between a DT and ADT in Minnesota. Again, these slides will be available, as I understand, at the end of the presentation. So anyone can kind of take a look at that. It kind of lays it out pretty nicely. Next slide. My day pretty much is a lot of restorative work. I can see a 3-year-old, and on my way walking out, I'll see a 103-year-old. It's probably the favorite part of my job is the prevention education part. We get to help the hygienists a lot that have had a lot of that burden in the prevention education part of helping with patients and with families, especially with this patient population. So, you know, Hall Crown stainless steel, lots of SDFs, extractions of primary teeth. For an ADT, we can extract permanent teeth, but they have to be like class 3 mobile and pretty perio involved. And in my collaborative management agreement, I have to get permission from a dentist before I extract any teeth like that. For assessment and treatment planning, ADTs are the only ones that can do that. We can do limited exams, periodic exams, and exams for 3-year-olds and unders. We cannot do a comprehensive examination. That has to be done by a dentist. There's a lot of collaboration that goes on daily between me and the dentists that I work with, but just kind of understanding from a practice space that I cannot do comprehensive examinations. We can refer to specialists. We cannot prescribe. We can dispense and administer and provide certain medications, but we do not prescribe. I've worked in many different clinical settings. I usually have one assistant, we'll run 2 chairs, a lot of walk-in, you know, emergencies, helping to assess, and just getting a lot of patients out of pain, and working a lot with children, which is great. Especially here at the FQHC, we have patients that are uninsured and state-based, and it's a really great population to work with. So I've enjoyed it a lot. Next slide. This is my lovely son losing his first tooth in hockey, so I'm in for a world of fun. Mainly, this is just to show that it's been working. No matter what you've heard in other states, it's been incredibly successful in Minnesota. There's been lots of studies that have proven this also, and it increases access to high quality, people-centered care. As far as I understand, there have been no complaints or concerns that have been made to the Minnesota Board of Dentistry about quality or safety of care. We have some patients request dental therapists. And again, it's a well-accepted medical model. So among patients, it has really, no one's ever that I've talked to dental therapy wise had an issue with patient acceptance. A patient can be seen sooner from somebody that really kind of specializes in doing, you know, this type of work. So within the dentistry itself, you know, there's been some hurdles, and over the past decade, things have greatly improved. But overall, yeah, I love it. It's been working and having a good time doing it. So I will pass it back to Don, I believe, or we're doing a Q&A. Yeah.
Thanks, Katie. We will do some questions, and I've tried to read in the chat. One of the questions that has come up is, are there examples of the dental therapist either being in a remote, you know, situation on a mobile van, and or being able to work via supervision from or oversight, however your collaborative relationship is, via teledentistry? So could you sort of speak to those 2 things?
Yeah, I did teledentistry coming back from COVID, and several of the dental therapists, we have 4 in our clinic currently. So I know and some clinics are still utilizing teledentistry. So advanced dental therapy is great for the teledentistry model. A lot of dental therapists in Minnesota, there's some misinformation, like we're only working in the cities. I'll show you kind of maps later to show that's not true, but they do, their main office may be in the cities, but here at like Southside, they have a mobile dental unit. And at like Apple Tree Dental and Children's Community Dental Service, they go to like different sites, and they travel a lot, you know, utilizing teledentistry with their dentist to give really high quality patient-centered care. So yes, it's very, very common in Minnesota to go to rural areas with a van and set up in the corner of a gym and to see patients.
And there's one that's just come up, and I don't know whether you may, but you had a list. What kinds of codes are used for dental therapists when you're doing your assessments and taking in walk-ins?
What kind of codes? I mean, the same codes as you would for a dentist, like is that what you mean? Like
Yeah, I think that's what the question is because I think you had a listing of the procedures you did. So it's basically the same dental code you don't have to put up.
exact same codes as you would for a dentist that are approved by the board.
And, another question that's come up, and I'm not sure, this may be actually for you, Jeremy. We'll see if that's the case, is in the map that you showed about states that have it on the books, some of them working it on the books, and there are others that are rather pale, that either haven't thought about it yet or can't get any shades of pink or red. What are the sort of ballpark, thank you, there we go. What are the ballpark steps that a state needs to do with regard to, sort of getting some shading to their, white background?
Yeah, Don, I saw that question. To be frank, I'm not sure I can answer that in the next 3.5 minutes. I would say short term, as I was, and I know I was whipping through my slides. Ultimately, the way that dental therapists have been authorized, save for Alaska, that's a different example, but save for Alaska, ultimately your state legislature needs to pass a law that authorizes dental therapists just like any other type of provider, from a dentist to a physician to a nurse practitioner or any other type. The longer conversation is sort of how that the politics and the policy of that goes. I think it is fair to say that dental therapy is not universally supported in the oral health community. There are certain segments of the oral health community that are less supportive than others. But what I will say, and so there's a lot more to that story, is my point. I'm not trying to not tell you something. It's more that I think that it's very likely we will make this a part of the next meeting that we have, just to talk more about how states can effectively pursue this. But what I do want to emphasize, because folks that do more research in this, there are, in terms of the oral health community, dentists, there are some dentists that are more resistant to it than others. What I really want to emphasize or leave folks with in answering this question is one of the primary reasons that dental therapy has progressed so much over the last 15 years is because there are a significant number of dentists that have been very vocal about it as an integral part of oral health services. And Katie, I will let you are on the ground, so maybe you want to speak to that. But I just will really want to emphasize, in my experience on this issue, there's been so much progress because dentists have been vocal in how critical it is to expanding access to care. So, Katie, would you add anything to that? What I basically say to the person that asked that question is love to follow up and have a further discussion about this. But Katie, anything to add?
Yeah, no, I mean, that's where it's like, I'm sure a lot of people, like we're seeing in the comments, about just like, how can I get this passed in my state? I mean, you're an amazing resource. So if anyone can reach out, then that's what you did, forever. No, not a lot to add. It's important to remember it has only been, 10, 15 years since dental therapy first started. So there's now information and things coming, out. So the patients with that, and we're not flooding the market by any means. There's only about 120 of us practicing in the state of Minnesota. The class sizes are really, really small. So but we're doing good work, and that's showing, and it has slowly but surely, it's really taken hold.
I think some good news as we're looking at I feel like the early results coming in the chat. Looks like there's a bill in Colorado in the next couple of weeks. Jeremy's email has been posted in the chat if you want to chat with him more. The other thing I would say, and it's why I mentioned that there are people on this call who have been working on this topic for a long time. There are some amazing playbooks, that have information about steps to take with regard to your state, things that you can do, and learning from, sort of bruises that people received in the past, as well as successes that they have in the past. So we will certainly make those available to those that, have an interest. The one question that did come up, and Katie, I think you had sort of done the prerequisite of it by stating you were going to be talking about Minnesota. I think what one of the comments was, it varies by state of what is allowed And at least I think it also varies by title. In some instances, dental therapist is the word. Obviously, when I think about Alaska, I think about DHAT, so they may be by different names. But I think if I'm reading the question correctly and the response in the chat, I just want to confirm this with both of you. It does depend on the state, and the state defines what the educational requirements are, whether that's a master's degree, whether that's you have to be a dental hygienist first. It seems like that's what I was reading. Is that correct from the comments I was reading?
Yeah.
Katie, well, Don, I would concur with that. You've got 13 states all do it a little bit differently, with the common theme that dental therapists essentially have an advanced set of procedures that they can do that other oral health providers in the oral health team may not be able to do. Can I just say one more thing, Don, because I know we got to move on.
Sure.
All of these questions, the NAC team that is on here, we will, number one, collect all of these and we can answer them for sure. But number two, each of the sort of segments of speakers is going to have its own Q&A. And so if we don't answer, Katie and I haven't answered it in this segment, there's probably a good chance we'll be able to answer, us or other speakers will answer it over the next hour. I just want to share that, Don.
Perfect. Well, we're going to wrap this one up, but keep those questions coming. And the last one, yes, there is a proposal both by the recommendation at the National Advisory Council on the National Health Service Corps, as well as the Bureau of Health Workforce group on medicine and dentistry, that dental therapy be added to loan repayment programs for the National Health Service Corps. We will move forward with our next segment. Our next segment is going to feature the individuals you see on this slide. And it's that Mike Holmes will put on his CEO hat from Scenic Rivers Health Services and reflect on dental therapy from that perspective. And then he will be followed by two dental clinicians, one of whom you know, and another person who I will now introduce. The person you know, of course, is Katie Levinsky, and Katie will be joined by Dr. Rachel Hogan. Dr. Hogan is a general dentist and dental director of the Swinomish Tribal Dental Clinic, a National Health Service Corps alum. Dr. Hogan worked at a health center, CMAR, in Bellingham, Washington, for over 10 years. So I will turn it over to you, Mike.
Thank you, Don. So we'll take a quick run through on the next series of slides about dental therapists in Minnesota. So the first slide, 2009 was when the legislature passed the licensing authority to license dental therapists. This actually was a fairly significant political lift for us. It took multiple years, and we were battling a very aggressive Minnesota Dental Association. But it was the safety net providers, the FQHCs, consumer advocates, and the schools actually looking at addressing the workforce shortage that was growing in Minnesota to deal with dental access and being able to have access to dental care statewide. It took a while. The last two bullet points, I think, are really the important pieces of this slide. There are two types of dental therapists in Minnesota, the dental therapist and the advanced dental therapist. But it also required that these providers serve low-income, uninsured, underserved patients, and that they're practicing in dental HPSAs. And so that was the foundation for the law. And then also in 2010, which really allowed us to fully implement the law, is that the legislature authorized coverage and payment for dental therapy services for people in the Medicaid program and the Minnesota Care Program, that these were eligible providers for FQHCs to receive PPS reimbursement or APM4, which is an alternative payment methodology in Minnesota that currently exists. Next slide, please. So this is essentially a summary of Katie's earlier comments about dental therapists and advanced dental therapists. There are approximately 120 of them licensed in the state right now. Let's go to the next slide. And you can see them, most of them are in the metro area. And we're starting to see dental therapists in the rural areas of the state. Following the requirements of the statute, you can see that therapists are treating low-income uninsured patients, Medicaid patients, patients of color, populations that are have disabilities, perhaps needing interpreters, and also our veteran population. Next slide, please. The dental therapist workforce is a young workforce, but they have expectations that they're going to be in practice for a long time. As we look at training workforce for the future and trying to increase the workforce in health centers, dental therapists create a career path for a number of our dental support staff. If you look at a pathway of a registered dental assistant, perhaps going for additional training as a hygienist, and maybe then as an advanced dental therapist, it's a career path for our staff in-house and a way that we can work to develop additional provider workforce for our needs in the future. Next slide. This is a result of one of the satisfaction surveys. So far, the therapists that are in practice have a relatively high level of satisfaction. I think the first 8 class members that came out of the initial dental therapist program had a difficult time entering their workforce. We weren't ready for them when they became available to us. So it's taken us time as employers to create the environments to bring dental therapists into practice. Right now, about 14% of dental therapists in Minnesota are working in the FQHCs. That's approximately 20 dental therapists. 25% of the therapists are in community or faith-based organizations. Another 25% are in solo practice. And so we can go to the next slide. So this has been our experience. We have utilized ADTs, the Advanced Dental Therapist, since 2018. We currently have 3 of them on staff in 3 of our 4 dental clinic locations. Our dental clinic in Floodwood, which is a community clinic of a community of 600 people, is staffed by 1 dentist, 1 ADT, 1 hygienist, and then support staff. Our Big Fork Dental Clinic, which is in northern Itasca County in northern Minnesota, it's a community of about 400 people. We have 1 dentist, 1 ADT, and 1 hygienist. And then our Cook campus, small community, about 800 people. We have 3 dentists, but we also have 1 ADT and 2+ hygienists. Only one of our sites does not have a dental therapist right now on the provider team. That's our Tower Clinic. And the reason for that is we only have 3 dental chairs in that clinic. And so we have 1 dentist and 1 hygienist in that clinic. There's no other reason other than the lack of space and the lack of chairs. So our therapists right now are averaging about 1,350 encounters per year. You can see that the average per visit billing from the gross standpoint is about $285 with collections of $231. And that compares to our dentist's billings per encounter of $340 and collections of $285. This is not unusual. I think what it allows us to do with use of dental therapists on our team, it allows our dentists to do higher end, more intense procedures. So we have some of our dentists are doing endodontics and they're doing prosthetics. And so you'll see that reflected in their charges per encounter and collections. With 5 of our 6 dentists having ADTs on their teams, I think we've had a really good acceptance with our practitioners of a team-based model of care. We actually did not have any difficulties integrating therapists into our provider teams with the community or with our governing board. We use the explanation of the medical model of care. We've used mid-level or advanced practice clinicians, nurse practitioners and physicians assistants working alongside of our physicians in our 7 medical clinics, and we've done that for 40+ years. And so by saying to the community that this is a new practitioner, it's similar to an advanced practice clinician in the medical model. And so it's been well received by our patients in the practice. We typically use a warm handoff between our dentists and our therapists so that it creates a level of ease for our patient populations to know that they're receiving good care with all of our practitioners in our facilities. The one advantage that we've had by using ADTs versus dental therapists is the fact that with 2 of our small clinics with only a single dentist in, we can still keep our clinics open when our dentist is on leave, whether it's vacation or continuing ed, by having a dental therapist and a hygienist still seeing patients in that clinic. We have an integrated electronic health record. We're currently on Visolution's VisDent. And so if the dental therapist has questions, they can connect immediately to our dental director or another one of our dentists in another site. They can bring up the record, look at the digital imaging, and advise the dental therapist of best course of action. They also can do e-prescribing in the case of requirements for antibiotics because dental therapists don't have prescription authority in this state. So we've had a really high level of satisfaction in our patient surveys. The patients are certainly receiving our dental therapists well. We've had in peer reviews, the quality of work has been really, really good. And as we look to the future, we currently are participating with the University of Minnesota in a training agreement. So we have 4th-year dental students coming up in rotations for 4 weeks at a time, and we're taking 4 students at a time. This last December, the rotation was actually 3 4th-year dental students and 1 ADT student. So as the training programs switch to team-based care, we're seeing a change in the market. We certainly learned lessons along the way, but the most difficult fight is the political fight to get the legislative authority to allow for dental therapists to practice when you're within your state. But if you can win that battle, the advantage is considerable to the health centers and to increase levels of care to our patient populations. And at this point, I'm going to turn it over to Dr. Hogan.
Super. Can you guys hear me?
Yes.
Yes. Awesome. Thanks for having me. I might bring a whole nother level of perspective. We are really modeling how dental therapy started, like at the grassroots level in Alaska, because of just the traditional dental delivery model was failing all of these really remote Native communities. And Alaska had tried everything from like recruiting and reimbursing dentists at really high amounts of money, and then having them come and not stay or really be integrated into the community, to sending all of their patients into like more urban areas of Alaska. And none of those were really working or changing the trajectory of oral health care in those communities. And so they started looking internationally at what other models were out there, and dental therapy was one of them. And so as the success of Alaska went on, despite all of the controversy and the fight with the Dental Association, Minnesota looked at that model and said, this would be awesome. Let's see what we can do in our state. And at the same time, my small little tribe of Swinomish was like, what's happening up there? And it seems like it's successful. And can we bring this here? So I guess that's the story that I'm going to bring to you. I am definitely a clinician by trade. I'm not a great public speaker. I'm a general dentist, and I've been practicing, gosh, for like 20 years now. Very public health minded. I was at CMAR, which is a large community health center, for many years. That was the beginning of my practice. And then I transitioned to Swinomish about midway through that career. But I've always been very passionate about really what's in the best interest of our patients, and looking at like holistic and culturally responsive, still clinically excellent, public health minded dental delivery systems. And when I got to Swinomish and they were talking about this, I said, maybe can I learn a little bit more? And after, traveling up to Alaska, I was like, okay, I'm on board with this. And so that's the perspective that I'm going to bring to you guys today. Next slide, please. So a little bit of context about where I practice and what it looks like. Swinomish is it's a pretty small tribe in the northwest coastal region of Washington state. It's about 90 miles north of Seattle. The tribe has about 1,000 enrolled members, but the dental clinic itself has a user population of about 3,500 patients, and we're open to all Native American, Alaska Natives in the area. And then we see non-tribal Swinomish employees and some of our non-tribal youth center kiddos and those folks. The purpose and mission of the Swinomish tribe is to protect and enhance the quality of lives of all of their members by providing a combination of economic opportunities and a safety net of social services, to protect the culture and the traditional practices of the Swinomish people, to respect and protect the spirit of the ancestors that have gone before and future generations to come. To exercise the powers of our self-governance and secured by the Treaty of Point Elliott, and to protect and preserve the tribe's reservational homeland. So it's within this mission that it really guided all things related to dental therapy. Coming to the reservation, dental therapy was a native-born sovereignty-based solution, resonating with a lot of tribal leadership. And those leaders are recognized across the nation as very passionate, strong, stable, and visionary senators, is what we would refer to our tribal government as what is in the best interest of their people. When we talk about legislation, I could go into that. That's, I guess, another whole forum. But initially, Swinomish said, "This is great. Let's see about getting legislation passed." And trying to pass statewide legislation took years and years and years. And I think 7 to 8 years into it, we said, "Okay, we want this, and we want this to happen now." And so we ended up creating our own regulation licensing board and bringing down an Alaska trained dental therapist. The pictures on this slide, there is our dental clinic, the very large building with, gosh, it's probably, there's 10 windows there, and all of those windows are dental operatories, and they overlook the Swinomish Channel. So we have the best view on the res, and that's not an accident. It's because there's been so much historical trauma around dental care, and we really want people to come and feel like they are in a safe space, and that connection to the water is really important, that they have ownership over their treatment and that they are part of that. And then you can see my staff. So the clinic didn't always look like this. It was before it was about half the size. And in 2019, we did a big expansion project. So we went from 5 chairs to 14. Part of that expansion includes space for a dental therapy education component that we are also building. We expanded. So we brought down Daniel Kennedy. We can go to the next slide. I think that's the picture. Yep, there's Daniel. We brought down Daniel Kennedy, and he was like our inaugural dental therapist. He has since retired, but we now have 3 full-time dental therapists. I have 2 dental hygienists, and there's 2 full-time dentists. That doesn't include myself because I've been doing a lot of administrative work. But we're a pretty large staff, and we're doing some pretty cool things. As I had mentioned, there's a picture of our former chairman, Clattisby, and it was really the leadership of our Senate that said, we need to look at different delivery models because this isn't working for us, and what can we do? And we just push this through. The state of Washington has since recognized dental therapy, but only on tribal lands, and we're continuing to push to scale it up for statewide implementation. And I think that that's why our story is important, because the success that we have seen within our community that we modeled after Alaska can easily be shared among the state, among community health centers and private practice models if they choose to use it. Next slide, please. So again, kind of talking about the transformation, I think you can look at our building transformation and kind of equate it to the transformation of an oral healthcare delivery model. The very top picture, that was a single wide trailer that was delivered to the res in the 70s. And that was a big accomplishment because prior to that, you know, tribal members would have to travel to Mount Vernon or down to Seattle just to get treatment. Again, it was pretty much all emergency treatment. They lobbied the IHS to get this trailer, and they did. So for, you know, the next 25 years or so, at least there was some access to dental care, but this was still very unpredictable and sporadic because we had itinerant dentists filling in here in this trailer. And so it was inconsistent, and it was really culturally like just incompetent care. A lot of my elders still have severe dental trauma. They tell stories about the dentist coming out with just like a bloody butcher apron, because all you would get in there is extractions, and you could hear that those were going on and people didn't feel numb, and the stories go on, and then they pass that on to the next generation. So we have a lot of dental fears in our community. It's gotten a lot better, but it was in the 90s that we built the 5-tier clinic that we have since expanded on, and it was under our self-governance compact that the leadership at that time moved forward towards construction of this full service dental clinic. And then the next picture is, as I had mentioned, our 2019 big expansion. And then you can see sort of the inside. So all of a sudden we're working, not all of a sudden, but in today's date, we are really working in a state-of-the-art dental facility. We have all of the nicest bells and whistles, and it's because our community has really stepped up to say, this is super important to us. And we do a lot of things within our dental clinic. We work really closely with our medical. And when we talk about holistic care, we include things of like, we've been doing like Hep C testing. We've been doing diabetes screenings. We do like patients come in and it's pretty routine for them to be aware that they're going to be asked everything about their medical history. And if they're having trouble accessing some point in that we know who to reach and how to get a hold of them. Next slide, please. Oh, you're so good. So pretty much for us, it was really interesting when we were first looking at this. 80% of the procedures that I, as a general dentist, were doing were things that could be done by a dental therapist. And so I was spending a very significant amount of my time doing restorative work, much of it simple, if we could do even more prevention. And so bringing in just even one dental therapist made a big difference for us. We had lower wait times, increased access to care. We completed treatment plans a lot faster, and we had great community feedback. Just with Daniel, within those first 2 years, I was doing 50% more crown and bridge. So our lab was calling us like, what are you guys doing? Did you increase your patient population? But we were finally able to get through treatment plans so I could go into like some of the more fun things, both for myself and for patients. And at the same time, the dental therapists and I think next slide, because this talks about dental therapists in our community. Our dental therapists and our hygienists work together as a prevention team. We call them our hippy dippy team, our health promotion disease prevention team. And so they go to the daycare and the preschool once a week, actually every Wednesday, and they brush our kids' teeth. They also do visits to our school programs. We provide dental supplies, and we dedicate days every quarter where we have kids come into the clinic to provide exams and sealants and other treatments. We are available at every community event, from canoe journeys to our health meetings, and we join our health team even on home visits and going out and checking on our elders. It was interesting because during COVID, the dental clinic was so well known that, well, we ended up helping our medical team, and we were the ones, us as the dentist, delivering the vaccines, and all of our staff helping to do all of the testing and the contact tracing within the community. And it was because we had this large, really comprehensive staff. I think one of the fears was around safety and what that looked like. So it's really interesting. You do create a practice agreement, and you know, the speakers before us were talking about there are a lot of different acronyms for dental therapists. A lot of the Alaska dental therapists go by dental health aid therapist. Anytime we think of a dental therapist, we know we have a general idea of what that scope looks like. And we know that you're always going to be working in a practice agreement with a dentist or under a dentist, very similar to the way that a hygienist would work. And there's clinical excellence, and safety is always a priority. Really, dental therapists are masters at the skills within their scope. They can do a filling far nicer than I could, even though I've had extensive training, but it's because that's really what they focus on all of the time. Regulation is very clear and simple. I can't imagine not having a dental therapist as part of our practice, very similar to, I can't imagine not having a hygienist. Yeah, next slide. So for us, setting us up for success, or what it would look like in other clinics, there's definitely some fear or some holdback from dentists that have not gotten, that feel reluctant, mostly because of the safety or other things that they have heard. But dentists that have been working in public health really recognize the oral health disparities and the failures to address them with the current system. And they are abundantly aware of the Band-Aid being put onto what I would consider like a gushing wound, like just the tremendous amount of need. Problems with provider turnover, lack of investment, commitment, or experience, and difficult recruitment. So I think public health minded dentists really embrace this model, and they are happy to be able to help scale up a team and work at the top of their scope, and have everyone working at the top of their scope. We both, in my CMAR experience and at my Swinomish experience, we've always had dental students coming through that keep us really up to date with evidence-based models and practices, and has grown us as supervising dentists to be good teachers and mentors and preceptors. And I think that that's really important, to have your dentists on board. And I think it's really important to listen to your community and to your patients, and they are so receptive. I mean, we really have a community grown provider, and it's really amazing to watch the connection, the patient provider connection, and how quickly that is formed with a familiar face. We've talked about dental therapy, the benefits of that. Next slide, just 100% increase in prevention. I mean, the world is your oyster, where you wouldn't pay a dentist salary to be going out into communities. You can have your dental therapists, and in our case, the hygiene dental therapy team, go out and provide services and prevention. We don't have emergency walk-ins to nearly extent the time we did, decrease in patient wait time. In our clinic, we've started implant placement, and we have a Solea laser that we're also using. Those are things that we never would have been able to get to. Significantly reduced referrals, and great increase in patient satisfaction. Last slide. So Tigwitsi, that's Lashutsi for thank you. Happy to answer questions afterwards. Katie, sorry.
No, you're fine. A lot of this has kind of already been covered, but I just know it's kind of, so in Minnesota, we do call it a collaborative management agreement, a CMA. We have to renew this every year, and we do it through like within our clinic, and then the Minnesota Board of Dentistry, we go online and register every single year. The collaborating dentist has to be licensed and practicing in Minnesota. The collaborating dentist accepts all responsibility pursuant to the management agreement. One DDS in Minnesota can have up to 5 CMAs with a D tier and ADT. It's also important to note our CE cycle is the exact same as the dentist. Like every 2 years, we have to do the 50 hours. And as I point out in other states, your collaborative management agreement allows you to limit the scope of practice for a dental therapist or advanced dental therapist. So if there's a scope of practice like class 3 mobile extractions that you don't want the ADT to do, that you could put that in the collaborative management agreement. If I am correct, I still believe, at least in the state of Minnesota, there hasn't been a restriction as far as scope of practice for any collaborative management agreement, other than once someone is an ADT, they go other so many months of supervision before they can practice under the general supervision, where a dentist is not in the clinic. Next slide. Again, just to highlight, in Minnesota, and I know a few other states are following kind of a similar model, we are required to practice in settings that serve low income and underserved patients that are located in dental health professional shortage areas and who maintains an underserved patient base of at least 50%. In Minnesota, this was kind of a big freak out when we first graduated, because they're like 50% of my practice is not state-based insurance, but it's 50% of the dental therapist patients, not the practice patients. So I think that's important. But as you've seen just from all the data, about 100% of our patients are state-based insurance or uninsured. So that hasn't been an issue for any dental therapist in the state of Minnesota, and nor should it be. Next slide. We already kind of went over this. Just you can see we're doing what we said we do. Next slide. This is a study where this information done is by the Minnesota Department of Health from 2019. You can see from the quick links, just the kind of information that you can get. So if anybody wants to check out some more statistics, there's a lot for you there. Next slide. This is just from the University of Minnesota. This is just kind of where we are in Minnesota right now. There are dentists, therapists that have gone on to dental school. There are some that use the master's to get a doctorate in like kind of in a different professional healthcare field that are working on a state. We got the first one that was licensed in Minnesota. She's now working in Maine, which is amazing. And a few other states are working on that too. So again, just kind of slow momentum. We're just doing good things and spreading the word. Next slide. This state map is old. It's from 2018, but it kind of just shows that yes, dental therapists, a majority of us are in Minnesota in the metro, but it's important to note that most of the state-based, we're about 60% of state-based insurance patients live in the metro area and about 40%. So we're actually distributed in Minnesota, kind of where our patient population is also. And again, this does not include mobile sites, school-based or other community-based locations. This is just kind of like a single site where dental therapists are employed. Next slide. I think that's it that I have for questions I usually get in other states. So
I think we're going to do just a couple quick, one quick question that was asked is, Katie, do you carry your own liability insurance?
Through the FQHC, I don't have to. Through the large nonprofit I worked at before I was under their umbrella, there are dental therapists in the state of Minnesota that do and can carry their own liability insurance. So it kind of depends on the practice location. So you can, there are places in Minnesota you can definitely go for that, but I haven't had to personally.
Gotcha. And it was a request that we do mention that the Commission on Dental Accreditation does have accreditation standards for dental therapy programs, and that they did release some model regulations in February of 2022. I think given, it says for dental therapists who do carry liability, it usually costs about $100 a year. That usually reflects that there aren't many litigation cases because insurance companies aren't just not-for-profit, as the case may be. So I think we'll move on to our last presenter. Thank you to both of you in this group. It'll be our last segment. Then we'll have some time for question and answers at the very end. And the presenter for our final segment is really going to reflect on the roles primary care associations can play in advancing dental therapy in your state. So before coming to the Michigan Primary Care Association, Misty Davis provided care in the community as a dental hygienist for 14 years, and she continues as an active member of the American Dental Hygienists Association. Misty, I'll turn it over to you.
Thank you, Don, for the introduction, and thank you for the invitation to come and speak with the group today, and to everybody who has joined also to learn about dental therapy. I'm Misty Davis, Oral Health Program Manager at the Michigan Primary Care Association, and I was brought onto the team nearly a year and a half ago to support the implementation of dental therapy. So we're just going to kind of dive into what that looks like. So we're going to talk about what our stake is in dental therapy as a PCA, the oral health workforce and health centers and how dental therapy fits with that, the progress of dental therapy in Michigan from the perspective of the MPCA, and then why it makes sense to have a position dedicated to implementation at the PCA. Next slide. So Michigan Primary Care Association's mission is to support health center excellence in the delivery of equitable care. And we really strive to support our health centers in any way we can. And we see dental therapy really as an opportunity to support our dental clinics by strengthening their workforce and improving their ability to provide care to the people who need it the most. Next slide. So you can see on this map where our dental clinic sites are located. And of course, they're going to be located in areas where communities have significant barriers to care and generally areas that are difficult to recruit and retain providers. And so dental therapy exists really to improve access to care in underserved populations. And it was designed exactly for the communities that our health centers serve. And so it's really going to help strengthen our safety net oral health workforce and also allow our teams to improve access to care. In Michigan, we have just one version of the profession, and we call them just dental therapists, but it's very similar to the ADT model in Minnesota. So they can provide care without the presence of the supervising dentist, and they can really leverage the equipment and partnerships that health centers already have. And they can even broaden the existing models of care delivery to really help reach care into communities where people are. Also, health centers, the providers, they just really get it. They see the burden of dental disease in underserved communities. They're fully aware of the disparities that are created by the current system. And that is not to say that all public health dentists are ready to supervise a dental therapist tomorrow, but they don't need to be convinced that the safety net workforce needs reinforcement. And then unlike smaller practices, health centers have the human resources to really think through the angles and fully develop positions that make sense for the organization. There are a lot of angles to consider when incorporating an entirely new profession into an existing team, as you can imagine. So, so they really need kind of a team of administrators to work through that. And also PCAs add another layer of support. So the network that we operate within really affords health centers a lot of resources that can support dental therapy. And then finally, dental therapy and health centers really make sense because the dentists likely don't have the perception of financial competition, which is really a large reason that organized dentistry kind of rejects dental therapy. The dental therapists, they're just really cost-effective additions to the team, and they're only going to strengthen operations in the health centers. Next slide. So now we will look at the progression of dental therapy in Michigan, and our journey really started with a partnership between the Michigan Council of Maternal and Child Health and the Pew Charitable Trust. And that happened in 2014, and they championed the effort. They really started doing research. They gathered data and reports to support their efforts as they move forward. And then they found a sponsor for the bill, for the dental therapy bill in 2016. Senator Mike Shirkey sponsored our legislation. Then MPCA became really involved and we made it a policy priority. We joined the Michigan Dental Access Coalition, which was formed to support dental therapy. We did a lot of advocacy, talking with legislators, helped draft bill language, and coordinated testimony for health center dentists, who we had several that were strongly supportive, and we appreciated that very much. And then in December 2018, our bill passed, and then we shifted to implementation focus. So the Michigan Council of Maternal and Child Health were still very much involved. They saw that this was going to be a big lift. The implementation is going to take a lot of effort and time. So rather than piling the work onto somebody that already had a full plate, they partnered with MPCA to house my position and fund my position, and dedicated half of my time to dental therapy. And so I really feel like this is part of the reason we've come so far so quickly in Michigan. And any state that's moving toward dental therapy, I really encourage you to really dedicate at least a half-time position solely to implementation efforts. And then in April of 2021, our administrative rules were promulgated and we could license dental therapists. So that milestone was huge. Now we're into the green bubbles, and these are the current efforts right now. So the outreach and education that I'm doing is really focused on kind of three branches: potential employers, potential students, and potential educators. And I'm just really keeping dental therapy in the conversation and trying to keep people engaged and kind of normalize the idea of dental therapy for stakeholders. And I'm also looking for ways to align the groups with funding. So just last week, the Delta Dental Foundation committed to funding a $5,000 signing bonus for dental therapists to accept positions that are in our health centers. So we are so thrilled and so excited to have that development and that support from Delta Dental Foundation, and might just be a game changer for our recruitment efforts to Michigan. And also we partnered with the Michigan Department of Health and Human Services to submit a workforce grant proposal from HRSA, and that would support dental therapy implementation too. So my efforts around recruitment are, of course, focused on health centers, and we're going to be launching a pretty robust marketing campaign on behalf of the health centers that want to recruit dental therapists. And we have about 6 health centers right now that are really looking forward to that. So now the yellow bubbles are future events that we've been working toward, but we've not reached yet. And I'm thrilled to say, though, that we do have a university, Ferris State University. They're committed to developing a dental therapy program. We're working to support them in any way we can and really move that along. And of course, we're on the edge of our seat to see the first dental therapists become licensed and employed in Michigan. And then we do have some data collection to do, and that's written into our statute, but we also really want to be able to demonstrate what impact dental therapy is going to have on our state too. So next slide, please. So to kind of sum it all up, our mission aligns with supporting dental therapy. It just makes a lot of sense for us to support the profession. Health centers and PCAs have access to internal resources that make implementation kind of less of a lift. And we also have potential relationships with national resources. We do have relationships, but all PCAs might potentially have these that really help align you with kind of like-minded organizations who have similar goals. So NAC, NOAA, the Pew Charitable Trust, Community Catalyst, the National Indian Health Board. There are a lot of resources that were really instrumental in my ability to do my job. And really this cannot be done without relationship building and collaboration. So PCAs are in a really good position because they have great relationships with their health centers, and they have relationships with other local, state, national organizations that really help move things forward. So I think that's it. Next slide. Yep. that's it for me. So thank you so much. And I will kick it back over to Don.
Thank you very much, Misty. And a couple questions I think that came up, and I'm looking in the chat now. I'm trying to do several things at once here. But I think we have a question about that maybe you or others may wish to answer, but has this has your utilization or the planned utilization in your case of dental therapists been able to expand access, and how has that done so in clinics? I don't know, Mike, you sort of talked about that a bit.
Without a doubt, the addition of dental therapists has allowed us to see more patients each year. And if I look at the 3 dental therapists we've added, that's in conjunction to the 6 dentists that we currently have on staff. That's 4,000 more visits a year, and that's several thousand more patients that we're able to provide care to in our settings. In addition, it allowed us to keep some of our smaller one dentist clinics open when the dentists were away on vacation or continuing ed. So the therapists would be in practice with the hygienist. Those facilities are open, seeing patients, even though the dentist is not available on site. So there's no question in my mind that therapists have allowed us to see more patients. As we look at new clinic development, we will be looking at a team-based model for all new dental clinics, which would include a dentist and an ADT and a hygienist and support staff.
Thanks, Mike. I'm sort of asking my team members there. Are there other questions that I've sort of missed in the chat?
Hey, Don, I did want to speak to, because I know a couple of folks asked earlier on, and I think the question first came up when Katie and I were speaking, and it was asking about the position of the American Dental Association. And I did want to answer that. It's a really important question, and if folks can bear with me for like 90 seconds, there is some nuance to the answer to that question. The ADA has historically taken an adversarial position to dental therapy. It is not, I do not believe in the time that I was at Pew, and even now, I don't know whether they have formally ever quote unquote opposed, but I do think it is fair to say that they've taken an adversarial position. But where this has really manifested itself is when I was at Pew from 2014 to 2018, it really manifests itself at the state level, where there are state level associations that are aligned with the ADA that opposed pretty much all of the state bills that would or did authorize dental therapists at the state level. It is important that has shifted recently, where I think there are several states that have either, the state association is either not opposed or even supported some version of what was introduced. But here's the nuance that I really want to share. There are immensely impactful voices within dentistry who are demonstrating that there is significant support among dentists for dental therapy. And there's 2 things I want to share. We talked about CODA earlier. Considering CODA is essentially the accrediting body for oral health providers, it is housed within the American Dental Association construct, if you will, and is ultimately driven by dentists. It's notable that CODA has established standards that essentially ensure the effective practice of dental therapists. And one last thing, I would also consider this: many of the decision makers who are driving the future of the dental therapy workforce, oral health workforce, are advancing the profession. I'm talking about the University of Minnesota Dental School, which was so instrumental, along with a number of other schools, in standing up a dental therapy program. I'm also talking about the Harvard School of Dental Medicine, which strongly endorsed dental therapy several years ago. So my main message here is that the voice and the opinion of the ADA absolutely matters, and it's very important. It would be amazing if the ADA were vocally supportive of dental therapy, but I would just say their lack of support is not a true indication of the overall picture of the position of all dentists. So that's it. I appreciate folks bearing with me with adding those details.
We have time for some other questions. If you'd like to put them in the chat, we'd be happy to take advantage of this amazing panel that we've put together today.
Hey, Don, I just because I know not everybody follows each question in the chat. There was a question about, I think we might have covered this, but who can dental therapists supervise themselves And in Michigan, Misty had said DTs can supervise dental hygienists and dental assistants in the absence of a dentist. And then there was a question, a few playbooks were referenced throughout the presentation. Are those available for review? Don and rest of the NAC team, I think it is fair to say, like, this was purposefully an introduction. We have a lot of ideas about what we're going to put together in terms of clearinghouses to store information, what we're going to present on future calls. I will say a lot of these questions and comments that we're getting will help drive what the substance of those meetings are going to be. I think, we'll certainly send sort of a follow-up with some key resources. There are a lot of resources on dental therapy out there, so we'll obviously try to share key ones. Don, did you want to add anything? I'm just scrolling through the chat right now.
No, as I was looking at it, Jenna, the answer is yes. We will make them available. I think part of what we wanted to do with this introduction, as I mentioned in the beginning, was to make sure everybody understood what a dental therapist was, how they're being currently integral parts of teams in several states and the work that they're doing, and how we can expand this effort with, I think, what is all of our goal is expanding access to dental care is an important part of caring for the whole person. It will be available, and part of it is the reason that you're asking these important questions is how can we be most helpful? Because this is really the kickoff to a peer learning community. And we invite everybody that's on the call and others to join. We want to learn from each other. And as you may have gathered from some of the chat responses, we have some amazing experts out there. And we'll be happy to get whatever information is available that can be helpful to you, whether that's at the, what do we need to do in the States, which is what we asked Misty to talk about. How do we get this going in our state? We aren't any shade at this point in time. What do we do? And so, yes, we'll make that available. And at the end, we'll talk about how you can send additional questions to it. Well, there it is.
Hey, Don, Don, can I cut in? There's a question that I would love to have a couple of our panels might be able to answer. Is that okay? I didn't
do it.
All right. The question was, what is the general salary range for dental therapists? Yeah, Katie, do you want to answer?
If you want study and information, the University of Minnesota will be publishing a study of dental therapists collected from data in 2018. I'm hoping very soon. So you will get actual stats on that. The very broad answer to this, depending on your year of experience and dual licensure, and if you're an ADT or a DDT, I would say is kind of ranging in between, like starting like really low at like 35 upwards of 55 or plus an hour. But that just depends on like benefit packages and everything too. So I always just say, like, you get to pay me about half of what you would pay a dentist to still get really high quality patient-centered care. So, but there will be a study published this year with more information about rural and non-rural, and it breaks it down compared to hygienists and everything too. So
for us, it's about 70% of a general dentist salary.
That's awesome.
Hey, Don, I'll also just plug, because I've seen there were a few questions that Katie and I got at the top, and I'm seeing some more comments just about if you're in a state that doesn't have dental therapists. We will definitely follow up with more detail. That, there's only so much we could cover in 90 minutes, but I would just say in the short term, it never hurts to talk to the other folks in your public health advocacy community. I think that's a good place to start to take the temperature on this. But more to come on that. I know that's a very important thing that I personally worked on for 4 years. So I'm excited to have that conversation. So, Don, I'm not seeing anything else. I don't know if other folks are. I don't want to monopolize the conversation here.
No, I was looking too. I think we've covered most questions for everybody. Katja much more eloquently than I has put in how you can contact her. This is really the kickoff. We really would like to hear if you'd like to be part of a learning community. If you said, that's a little too much for us, but we really want some additional information. We're excited about this expansion effort. As Rachel and Mike both mentioned in the beginning, this is an integral part of our workforce strategy as we look to the future. Again, caring for the whole person, integrating primary care, oral health, and behavioral health so that we can have the package that every health center across the country wants to have. And I think dental therapists can be an important part of the answer to that. So I don't know, I'll ask our panelists if anything you wanted to jump in at the end.
Oh, it is important to note there are more open positions in Minnesota for dental therapists than actual dental therapists. So it is very competitive right now. And I think it just shows how much it's grown in the last 10 to 15 years. So it's been awesome.
Well, on behalf of all of us, I want to thank all of our speakers for taking time from your busy day to provide this information. I'd be remiss not to also thank an amazing number of people that are behind the scenes, making sure that this all happened and they don't get anywhere close to the credit that they deserve. And thanks to all of you, for spending this time. One of the things that excited me about the addition to the Olympics this year was they added to their motto, better together. And clearly this is a team effort. And we want to do whatever we can to be part of that team and to help everyone out. And I think if my magic clock is correct, we may have actually given you back 4 minutes this afternoon. So that will be our gift to you. Yes, the PowerPoint and the recording will be available to everyone that presented. Thank you so much and have a super fantastic rest of your afternoon. Take care.